Hello and welcome to this another session of critical care training and discussion where we try to simplify the common emergencies which we face in the ICU and we try to give the bedside solution. Today's topic of interest is very common electrolyte imbalance or electrolyte emergency which come in the ICU is hyponatremia. The learning objectives for today's discussion will be to touch upon the physiology, very important, the water balance, sodium and understanding tonicity for simplification of approach for treating such patient. We need to understand about the IV fluids used in the critical care. We will define and classify the hyponatremia and we will try to give the case-based approach with evaluation of hyponatremia based on volume status and osmolarity. What are the various modalities of treatment? How does the tolvaptan work? And we are going to touch upon osmotic demyelination syndrome, which is one of the feared factor as we are chasing the rate of correction of sodium in a hyponatremic patient. So first thing first, what is the total body water? So we should know that the total body water in liters in adult male is 60% of the body weight, that is 0.6 into body weight, so 70 kg is equal to 42 liters. What is the total body water in average female? Is little bit lesser, that is 0.5 into body weight, say 50 kg is 25 liters. So the idea of knowing this is the total body water is depending upon the body weight, but then if the patient is obese, it doesn't mean that he has a higher body weight fraction, total body water fraction. In fact, it's the fat content is more and they are more prone for dehydration. So total body water is less compared to a lean individual. Similarly, the patients as we elderly more than 65, they also tend to have a lesser body water compared to the young adult. Now once we have understood the total body water, how it is distributed, if there is 60% of the total body water, the distribution is 40% of it is intracellular and remaining 20% is extracellular. The extracellular has two components further. One is interstitial, that is between the cells, interstitial, which is 15% of total body water, and 5% is intravascular. Why this is important to know is because when we give IV fluid in the body, the distribution as per the osmolarity and maintain the electroneutrality, any fluid follows this principle and in distribution that we will see. So third thing to understand is about the osmolarity. What is osmolarity? So if we see, osmolarity is amount of solutes or concentration of dissolved particles in the blood sample, especially the serum portion, and it is expressed as milliosmol per kg. It can be calculated or sent in the lab. This we discussed in the ABG session as well. You can calculate by 2 times sodium, glucose by 18 plus BUN by 2.8, or you can go in the lab, do it with freezing point depression method where the not calculated osmoles are also calculated and it give a value of serum osmolarity. What is practical we should know is that normal serum osmolarity ranges from anything between 285 to 295 milliosmol per kg. So going back to understand about the osmolarity here, if we have a solution and we have this container and there is a solution where there is less number of solute, another container where we have more number of solute, and another container we have say isoosmolar. So this is a hypotonic solution with low osmolarity. This is a hypertonic solution with high osmolarity because of increased content of solute, and here it is the isoosmolar solution. What is important, what happens to the cell when cell is exposed to this kind of situation? So if we have a hypotonic solution and this is our cell, there will be flow of water from higher water potential to low water potential, and there will be swelling of the cell. So that's the reason we don't use hypotonic solution practically in patient with head injury or with cerebral edema. There is chances of the cell swelling and say increase in the edema. Hypertonic solution, on the other hand, if we place a cell here in the hypertonic solution, the water potential is opposite from the cell to the solution, so there will be shrinkage of the cell. So that's why we use this hypotonic saline or hypotonic solution or increase the osmolarity for patients to reduce cerebral edema. So this is hypertonic solution. What happens in isoosmolar solution? There is no change in cell size, and these are ideal for maintenance fluid which we use. So before going for the understanding of IV fluids, let's see how they are distributed. So if we draw again a linear, this is our intravascular compartment, this is intravascular compartment, this is interstitial compartment, this is intracellular compartment. If we give a solution which is hypotonic here, which is solute free, the best example being 5% dextrose. If we give that 5% dextrose, what remains after utilization of dextrose is water for injection. This water can flow freely across the membranes from interstitial to intravascular, interstitial to intracellular, or on the opposite direction depending upon the osmolarity status. That doesn't require active transport. On the other hand, the sodium containing solution, or what we call a crystalloid solution, isoosmolar, isotonic, they remains in these two compartments, that is intravascular and interstitial. So distribution is 3/4 remains in the interstitial compartment after 20 minutes of giving, and 1/4 remains in the intravascular compartment. What is important is if we have say a blood loss of 250 ml and we are trying to replace with crystalloid sodium containing solution, we have to give 3 times the blood loss. That if I give 750 ml of blood of fluid, then the 250 will remain in the, so 1/4 of it will remain in the intravascular. So if I give 1 liter of ringer lactate or a normal saline, so 250 will remain in the intravascular, remaining will go in the interstitial compartment. What will happen if I use a solution with high osmolarity like 3% saline, or I give a protein solution, the albumin 5%, 20% albumin, these are the plasma volume expanders or colloid. How does they work? So if we draw this simple principle again here, intravascular, interstitial, these albumin solution or colloid remain in the intravascular compartment. They are increasing the osmolarity. They draw the fluid from the interstitial compartment, and in this way they causes the plasma volume expansion. So they are known as plasma volume expanders. So that is how the colloid acts. However, some of the colloids we are not using, off-dated, are hysteril and volumen hemacil because of various renal injury associated with this solution. So with this physiological principles in mind, let's go and discuss about the common IV fluids we use in the ICU. We have the solutions which are having the osmolarity within the normal range of 285 to 295. If we see the 3 common solutions, crystalloid which we use in ICU is ringer lactate, your normal saline, and plasmalide. So one principle is about the osmolarity and other principle is about the balance of electrolyte in that. So if we see ringer lactate, though it is little bit hypotonic solution, that's why we are not preferring in head injury patients. And you see that sodium is 130, potassium is 4, chloride is 109, lactate is 28, which is a buffer base, gets converted to bicarbonate in the liver. And it is a very ideal solution and mimics what is seen in the plasma. So it is a balanced Hartmann solution. Very good solution for maintenance in otherwise patient with the normal liver function. If there is hepatic hypoperfusion, then definitely this lactate load will increase. And being hypotonic, as I already told, we are not going to use in a head injury patient. In inflammation and pancreatitis and sepsis, still we can use the ringer lactate solution. Next solution we see is a plasma light here, which is the osmolarity is better than ringer lactate, and the pH, the sodium electrolyte contents, and the acetate instead of bicarbonate, which can get converted to base in other sources rather than liver. So it appears to be fruitful solution for today's best choice for any patient in ICU, and most of the time the solution used is plasma light because it's a balanced as far as electrolyte is concerned and as far as the osmolarity is concerned. So it can be used in head injury patients. So it is a balanced crystalloid solution. Coming to normal saline, if we see the osmolarity is high here, is 285 to 95, slightly on hypertonic side, and the abnormal electrolyte here is a chloride, is 154, way more than what we see in the plasma, that is 98, 99. So this is actually speaking having a good osmolarity, isoosmolarity, but it has got a unbalanced solution. It is an unbalanced solution that has to be kept in mind when we are over treating or when we are giving too much of normal saline. We can land up with a chloride toxicity. This is a content which can cause problem with the renal injury, as well as increase in chloride will lead to what is known as hyperchloremic metabolic acidosis, which we discussed in ABG section, one of the cause of normal gap acidosis, hyperchloremic metabolic acidosis. The other two solutions which are used is, one is 3% saline. Its importance for today's topic because we are using, this is very hyperosmolar, hyperoncotic. You see 1026 osmolarity, and again the sodium 513 milliequivalent and chloride 513 milliequivalent, of course used in situations of severe hyponatremia, and the rate of correction we will be discussing, as well as the patients with head injury to reduce cerebral edema instead of mannitol, with frequent monitoring of sodium till we can give 3% saline, till we monitor and should not allow the sodium to rise beyond 155. So that use of 3% saline solution. About 0.45 normal saline, somehow it's a hypotonic solution and often used when you have water excess or hyponatremia. It's a hypernatremia. On the other hand, if there is an excess of sodium there, 0.45 saline may play a role, but it's mainly free water which we should aim at. It's a hypotonic solution. So once we have understood the application of these common IV fluids, let's go to the case of hyponatremia. How do you define the hyponatremia and severity? So normal lab value is 135 to 140 milliequivalent per liter. Any sodium less than 135 is mild hyponatremia. Anything less than 120 with symptom is severe hyponatremia. Even some guidelines says that less than 125 milliequivalent with the neuro symptoms can be considered as a severe hyponatremia. The whole important point in understanding is the onset and the duration. How was the onset? Whether it is acute onset hyponatremia, which is draws the much more attention to treat, or it is a chronic hyponatremia over a period, that is important to explore from the history. Let's start with the case. This is a 60 kg female which presented with altered mentation, confusion, was admitted in neurointensive care. Remember, this age of female maybe 60 years, 65 years. Any elderly patient, most commonly dropping with altered mentation, you should not stick to, you should definitely do CT scan brain plane before labeling it as a metabolic cause for altered mentation. So CT brain plane was done, which showed just mild cerebral atrophy in this lady, and the abnormal lab reported sodium of 115 milliequivalent. So what is the next step in correction for the sodium in such situation? So as I told, the first thing is the history. Presentation is important. You have to ask certain medication histories. Often these elderly patients are on combination antihypertensive drugs. They may contain thiazide or some diuretic which we are taking long term, leading to chronic hyponatremia, or certain psychotropic drugs which may lead to hyponatremia. You should ask and probe in about the history of malignancy, whether there is possibility of syndrome of inappropriate ADH which is associated with various malignancies. And then of course the severity of symptoms, the neurological symptoms like lethargy, disorientation, repeated fall, osteoporosis causing fracture risks, headache, seizure is a warning signal that rapid correction may be required, and syncope and nausea. These are the neuro symptom, neuro manifestations because of hyponatremia, severe hyponatremia. Apart from history and clinical investigation, we have to assess two important things before we want to treat with any modality. We have to check for the volume status of the patient. And today clinically we can get a clue from the skin turgor of the patient. We can check the vitals, tachycardia, pulse pressure, how is the sitting and supine pressure. We can very well get idea of volume status with orthostatic changes in blood pressure. Certain lab parameters like increase in hematocrit or hemodilution, blood urea nitrogen, increase in BUN, creatinine, serum protein, uric acid. These are all the markers which will give hint about hypo or hypervolemic status of the patient. Of course, in hospitalized patient, if there is an invasive line, we can monitor this central venous pressure, and which are indirect indicators of volume status, the pulmonary capillary wedge pressure, the stroke volume variation, and with the advance of a bedside ultrasound, now very well we can define about the IVC collapsibility index, size of the IVC more than 2.5 cm is a hypervolemic patient, lung ultrasound B lines more than 4 lines, 3 lines. Easily a newcomer can assess and the volume status of the patient before planning for treatment of hyponatremia. Another important thing is to measure the serum osmolarity or get it from the lab. The most important investigation not to forget is the blood sugar level, the lipid and protein level. Sometimes you may get pseudo-hyponatremia because of increase in blood sugar, lipid, hypertriglyceridemia and proteins. The other investigations which are required is very much of importance is to send the urine sodium and urine osmolarity, serum thyroid stimulating hormone, creatinine, urea and serum cortisol. So these are of importance panel to be sent for planning the treatment. Once you have assessed the volume and osmolarity, your patient will follow in one of these 5 categories. So either he will be euvolemic and there is a hypoosmolarity less than 285 serum osmolarity and hyponatremia. Whether it is hypervolemic, hypoosmolar hyponatremia where the patients like congestive cardiac failure or liver failure, nephrotic syndrome, these will be hypervolemic, hypoosmolar hyponatremia. Or patient with GI renal losses or thyroid diuretic has become hypovolemic, hypoosmolar hyponatremia. Or patient may have hypertriglyceridemia, which we discussed, hyperproteinemia. They can have pseudo hyponatremia, isoosmolar hyponatremia, like high blood sugar may have falsely low falsely low sodium, and that may mimic as hyponatremia. So coming to the case about rapidity of symptoms and severe hyponatremia, if the patient is sodium is 115 and there is a seizure on admission, you have very well ruled out that there is no metastasis. They have done the CT scan brain and patient in post-ictal phase. Here the rapidity of correction of sodium is important and you have to use a 3% normal saline in such patients. How do I calculate the dose? Now we know that sodium deficit has to be calculated, and we know that rapidity of correction can cause the osmotic demyelination or central pontine myelinosis. So that's why we have to correct the desired sodium, that is to be kept around 8 to 10 milliequivalent more than what is the measured sodium at which symptoms have occurred. Suppose the measured is 115, we want to give the safe transfuse, so 3% saline. So I want to increase my desired sodium by 10, that is 125, and body weight is 0.5 into body weight of the female. So 60 kg is 30 into 10, That means my total dose requirement 300 milliequivalent per liter. 300 milliequivalent is the requirement. So now this 300 milliequivalent, how should I transfer 3% saline? I know that 3% contains 513 milliequivalent per liter. So 1 milliequivalent is 1 by 513 into 300. That turns around something like 5.5 or 600 ml of 3% saline. That has to be given over this 10 milliequivalent. I have to replace in 12 hours. So you can divide 600 by 12. That is around 50 ml per hour. So that is how you calculate, but you have to at the same time measure the sodium at frequent 6-hourly interval because of the loss of sodium from urine or other sources and to other fluids which the patient is receiving, to know exactly how much sodium is rising, and we have to keep monitoring the sodium. Another formula to find out how the increase sodium by any fluid, infused sodium plus potassium. If you say take a isotonic saline, which is 144 milliequivalent of sodium infused, potassium is 0, and serum sodium is, suppose your serum sodium is 100 and total body water is 0.6 into body weight at 30 plus 1, 31. So you can know that with 1 liter of infused sodium, your rise in sodium will be approximately 1 to 2 milliequivalent for 1 liter of normal saline. So for any infused sodium, you can calculate how much the sodium will rise. Rather than this complex calculation, there is a quick bedside rule. For hypertonic saline, the infusion rate is the weight of the person by the desired rate of correction, which can give an approximate value. Like if the weight of the person is 50 kg and your desired rate of correction is 0.5 milliequivalent per hour you want to correct, so it will be 50 into 0.5, that is 25 ml per hour. If you want to correct it little bit more rapid, so 1 milliequivalent per hour, so 50 into 1 is 50 ml per hour. So this is how you calculate the infusion rate, and of course you will be doing repeated sodium for evaluation. Coming to our cases of euvolemic hypoosmolar hyponatremia, if there is underlying malignancy, patient is euvolemic, and you have assured that there is a normal renal, hepatic and adrenal thyroid function, then you can call, because of the inappropriate ADH, antidiuretic hormone, there is a hyponatremia. So you have to ensure renal, hepatic, adrenal thyroid function to be normal. Urine sodium will be more than 40, serum osmolarity is less than 275, and urine osmolarity is more than 300. What to do in this situation? If the patient is symptomatic with seizures, and you have to restrict the intake, water intake to 50% of the output, that's 600 1000 ml, 3% saline depending upon the severity of the hyponatremia, and you can consider the use of oral vasopressor antagonist, that is tolvaptan 15 milligrams once a day. The dose can increase to BD, TDS, and maximum you can go to 60 milligram per day. So how do the tolvaptan works actually? If we see that normally there is a antidiuretic hormone, there is a vasopressin which stimulates the V2 receptors in the near the collecting duct in the nephron. This stimulates the cyclic AMP, and this stimulates the pyrokinase, and what the pyrokinase does is this increase this, what you are seeing is aquaporine channel. So these aquaporine channels are increased because of inappropriate antidiuretic hormone, and that leads to increase in the water absorption through this aquaporine channel, and this increased water will ultimately reduce the osmolarity and reduce the sodium and lead to hyponatremia. So in these situations of inappropriate ADH where this V2 stimulation happens, you can stop, you can use a drug which stop this act at this level. So that is what tolvaptan does. It stops the stimulation of V2, thereby decreasing the expression of these porine channels, and this decrease in porine channel will cause more urine, more water to be lost to the collecting duct, and less water will be absorbed in the serum, leading to rise in the sodium. But you have to be careful in patients with correction of sodium, should not be very rapid, and you have to adjust the doses. Sometimes there is evidence of pulmonary embolism, and CCF, congestive heart failure patients. You have to be careful in those patients, and these are one of the reports with tolvaptan. Coming to hypervolemic hypoosmolar hyponatremia, as I already told, increase in the volume excess in cirrhosis, nephrotic syndrome, cardiac failure patient, renal failure patient. The treatment will be to reduce the water excess, fluid restriction to 50 or 60% of the intake, loop diuretic, treating the underlying cause which has precipitated this condition, and avoiding the extra sodium. The third type, hypovolemic, where the GI loss or thyroid or excess or diuretic excess, or sometimes the CNS condition, which is sometimes difficult to differentiate from SIDH, is cerebral salt wasting syndrome. But remember, there will be volume depletion in cerebral salt wasting syndrome, and there will be increased urea, there will be dehydration. You can check from hematocrit, and on the other hand, SIDH is euvolemic or hypervolemic. So you can differentiate these two conditions, and the plan will be here the volume replacement and treatment of the underlying cause. If there is hyperosmolar hyponatremia, the agent which is causing the hyperosmolarity, like hyperglycemia and mannitol, which causes pseudo hyponatremia, in such situation you have to bring down the sugar by 75 to 100 milligram per hour with use of insulin, or you can stop the infusion mannitol and treat this hyperosmolar hyponatremia, where the osmolarity is high and sodium is low. In isoosmolar hyponatremia, you have to rule out the lab error. Sometimes drip arm sample was taken from the saline port where it's going, because of dilution you get the pseudo hyponatremia, or because of hypertriglyceridemia or hyperparaproteinemia. In such situation, you have to treat again underlying cause, and mast inactivity may not require 3% or other actions. Now, important regarding the rate of correction, as I told, in severe neurosymptom, we need to correct with 3% saline, and what is stopping us from rapid correction is the risk of central pontine myelinosis or development of a condition that is not only limited to central pontine but osmotic demyelination syndrome. There have been many studies done about this, and this the latest meta-analysis from the JAMA is good to read. You can go through this article of correction of rate and clinical outcome in severe hyponatremic patient, a systematic review and meta-analysis. Before going to that, we should understand what is osmotic demyelination. It is because of the rapid correction of sodium. There are osmotic changes. As I told, the cell shrinks and swell in hypotonic, hypertonic during physiology were discussed, and this rapid correction will cause the affection of pontine, extrapontine structures you see in the brain here. So there is a demyelination seen, and this leads to what is known as the locked-in syndrome, impaired consciousness, present with dysarthria, dysphagia, sometimes pseudobulbar palsy, and in severe state may lead to coma. So you have to be aware about this condition when you are trying to be very fast in correcting the sodium. So in this previous study, meta-analysis, what they have done is actually they have compared the fast, the medium and the slow rate of correction, and they have seen that you can correct up to 8 to 10 milliequivalent per liter per 24 hours without much side effect in a patient specifically with severe hyponatremia where sodium is less than severe symptoms are present. So you can go up to 8 to 10 milliequivalent per liter per hour. If you see, all these studies have not checked very high rate. They compared 8 and 6 and 4 and 6. So in clinical practice, we never go this slow, very slow. 4 to 6 milliequivalent per liter per 24 in symptomatic patient is out of question, and we have to target one of these to reduce the risk of hyponatremia induced injury and the rate of correction. What is in the practice changing about transfusion? 3% saline. What they have mentioned from this meta-analysis is correcting severe hyponatremia, don't go too slow. Though the earlier guidelines have mentioned less than 8 to 10 milliequivalent or 10 to 12 milliequivalent 24 hours, depending on the severity of the patient and monitoring of the sodium, you can go up till 8 to 10 milliequivalent per liter per hour. Thank you very much. Thank you for your kind attention.